Good evening, colleagues in Singapore. Good evening, everyone taking part on ESC Asia. It would have been great to be together. It would have been great to do the things the normal way, but we live in the times that we do everything based on video transmissions. It's better than nothing, and also we have a good thing on the horizon. 2 vaccines on the come, so let's see where that goes. Maybe next time we will be together. For now, we're going to do our best, and we're going to have a lot of new information coming from trials in Asia, the latest breaking trials from Asia, and I'd like to start introducing our first speaker, Dr. Park. He's going to speak about prasugrel-based de-escalation after PCI in patients with acute coronary syndrome, the host-reduced Polytech ACS trial. Dr. Parks comes from Seoul, Korea. Welcome, and we look forward to listening to your presentation.
So thank you, Dr. Bax, for the introduction. Because of time limitations, I will just go directly to my presentation. So this is my conflict of interest slide. So the host-reduced Polytech ACS trial was an investigator-initiated randomized trial sponsored by Seoul National University Hospital. We received research funds from the following organizations. So for ACS patients, aspirin plus a potent P2Y12 inhibitor, namely prasugrel or ticagrelor, are currently recommended as the standard therapy. There is a temporal change in ischemic bleeding risk after PCI. As you can see here, in the acute phase after PCI, there is a very high ischemic risk and a moderate bleeding risk. However, during the chronic phase after PCI, the ischemic risk decreases rapidly while the bleeding risk maintains, and relatively, the bleeding risk outweighs the ischemic risk during the chronic phase. Therefore, de-escalation therapy may be an optimal strategy to match the temporal change in ischemic bleeding risk after PCI. Also, we reported in a patient-level meta-analysis of over 16,500 patients that there is a disparity in ischemia and bleeding between East Asians and non-East Asians, where ischemic events are much more prevalent in non-East Asians, while bleeding outcomes are twice as high in East Asians. And when we looked at the probability ratio between bleeding risk and ischemic risk, patients with higher bleeding risk than ischemic risk was about 1/3 in Asians, however, only 0.4% in non-East Asians, showing that East Asians have a higher propensity for bleeding. Therefore, the objective of the current study was to investigate the efficacy and safety of prasugrel-based de-escalation after PCI with second-generation DES implantation in ACS patients. And our working hypothesis was that a de-escalation strategy will be non-inferior to the conventional strategy using prasugrel after PCI in ACS patients regarding net adverse clinical events. So the net adverse clinical events was defined as all-cause death, non-fatal MI, repeat revascularization, stent thrombosis, CVA, and BARC 2 or greater bleeding risk. And after doing a sample size calculation, we would need about 2,400 patients to prove non-inferiority in terms of the primary endpoint. So design of the current study was that patients would be randomized either to the de-escalation group or the conventional group. The first month, all patients would receive the conventional therapy of aspirin plus prasugrel 10 milligrams. After the first month, the de-escalation group would reduce the dose of prasugrel to 5 milligrams, while the conventional group would continue to receive the conventional dose of 10 milligrams. To note is that the core indication of prasugrel is less than 75 years of age, body weight greater or 60 kilograms or greater, and those without a risk of TIA or stroke. So these patients were not included in the current randomization, and they were included in the observational group. So we screened about 3,500 patients with ACS. Of those, 2,354 patients were randomized, 1,170 in the de-escalation group, 1,168 in the conventional group, about 96.4% completed follow-up, and then 96.7% completed follow-up in the conventional dose group. So if you look at the baseline clinical characteristics, they were well balanced between the two groups. However, the mean age was slightly younger because patients that were older were included only in the observational group. Predominantly males were enrolled. About 40% had diabetes. About 3% of the patients had chronic kidney disease, which was defined as serum creatinine greater than 2. And then also regarding ACS, about 60% of the patients were unstable angina patients, suggesting that they were relatively lower risk ACS patients. Also regarding the lesion characteristics, about 50% had multivessel disease, about 30% had multivessel intervention, and IVUS was used in about 1/3 of the patients. If you look at the primary endpoint, the de-escalation group, the primary endpoint occurred in 7.2%, while in the conventional group, primary endpoint occurred in 10.1%. The absolute risk difference was 2.9%. The upper limit of the one side is 97.5. Confidence interval was minus 0.7%, which was well within the non-inferiority margin of 2.5%. The number needed to treat was 34. So the p-value for non-inferiority was met in this trial. When we did a log rank analysis for superiority, we saw a 30% relative risk reduction regarding the primary endpoint that was very statistically significant. Because all patients received prasugrel 10 milligrams, same treatment up to the first month, and then the therapy was different from 1 month onward, we did a landmark analysis of the primary outcome. Within the first month, there was absolutely no difference between the two groups. After the first month, there was a 34% relative risk reduction in the de-escalation group. Also, the key secondary outcomes were differentiated between the efficacy outcomes and the safety outcomes. What was reassuring was that regarding the efficacy outcome, up to 12 months, there was absolutely no difference between the two groups. Numerically, the de-escalation group had a lower event rate than the conventional group in terms of the efficacy outcomes. In terms of the safety outcomes, there was a 52% relative risk reduction in the de-escalation group that was statistically significant. Also, if you look at the individual endpoints, you can see that regarding the benefit of the bleeding endpoints, most were due to BARC type 2 bleeding because BARC 3 or greater bleeding was not different between the two groups. Also, when we did a subgroup analysis, we showed that the treatment effect of de-escalation was very consistent regardless of any subgroup. So the current study has several limitations. Due to the core indication of prasugrel, the high-risk patients with frailty were excluded from our study. The non-inferiority design of the study may limit the interpretation of the superiority of the de-escalation group. The study was not double-blinded, and investigators were aware of which arm the patient was enrolled. Our results cannot be generalizable to all ethnicities undergoing PCI, given that our study was performed in a dedicated East Asian population who are known to have higher bleeding risk. And also, there was a lack of power to detect differences in the risk of ischemic endpoints such as non-fatal MI, stent thrombosis, and ischemic stroke. So in conclusion, ladies and gentlemen, in ACS patients receiving PCI, de-escalation of prasugrel from 10 milligrams to 5 milligrams after the first month was non-inferior to the conventional dose strategy for net clinical events. The de-escalation group showed significantly lower rates of the net adverse clinical events, mostly due to a decrease of bleeding events without increasing ischemic events. Our findings suggest that prasugrel-based de-escalation strategy could be the optimal strategy to balance ischemia and bleeding risk for patients with ACS treated by PCI, especially in East Asians. And I'm glad to report that our study was published in Lancet. Thank you for your attention.
So thank you, Professor Park, for this very important study, and congratulations for leading it and for the publication in the Lancet. This has important consequence for clinical practice, and this is in line with the current trend to decrease multiple antithrombotic therapy in duration or in dosage or both of them. I noticed that, not surprisingly, there is a superiority of the de-escalation strategy with regards to bleeding events. But although the study was not powered to assess ischemic events, of course, I noticed that even for ischemic events, the number of events was lower in the de-escalation group rather than in the conventional group. So the superiority, the overall superiority was not achieved at the expense of a slight increase of ischemic event, but it seems that on both sides there was a benefit. Can you elaborate a little bit on that?
Yes, so that's absolutely true. We found because the study was not powered to detect differences in ischemic events, we can't really say with certainty, but if you look at just the numbers in terms of the numeric outcomes, you can see a lower rate of ischemic events in the de-escalation group. What we did when we went into more deep analysis is what we found was that because of the small bleeding, there were more instances of discontinuation of the conventional 10 milligrams of prasugrel because of easy bruisability, what have you. And what happened was, because of that, there was more bleeding in the 10 milligram group, and that led to more discontinuation of therapy in the 10 milligram group compared to the 5 milligram group. So I think that may be one reason where why we saw numerically lower rates of ischemic events in the de-escalation group.
Okay, thank you. And in your limitations, you address the problem of the generalizability of these findings outside a South Asian population. You mentioned the different balance between ischemic and events and bleeding, and maybe also some differences in drug metabolism or issues due to patient body size.
Yeah, sure. So, it's well known that the East Asian population, namely Chinese, Japanese, and Korean populations, maybe have maybe a less propensity for ischemic events and a slightly greater propensity for bleeding events, and it's called the East Asian paradox. And because this study was done in a dedicated Korean population, I think it has to be strictly, taken into context and not blown out of proportion regarding generalizability. Also, another thing that we need to think about when we think about the generalizability of this study was that because of the core indication of prasugrel, if you look at the baseline characteristics of our patients, they were predominantly male in about, so 90% of the patients enrolled were male. The mean age of the patients were only 58 years of age, which is much younger than most of the so-called all-comer studies. So we have to make sure that this study, the results of this study are taken into context in patients with lower risk ACS and also mostly male and a younger population. So it is still not for certain whether we can see the same benefit in much older patients, in women, and in more higher risk ACS patients such as ST elevation MI.
Okay, thank you for this word of caution, but nevertheless, congratulations again for this important trial. Thank you, Dr. Pak.
Thank you, Dr. Iung.
Well, that was an excellent presentation and a publication in The Lancet. Wonderful. So we go now to our next presentation, and that will be given by Jasper Tromp. As you can see on the title slide, he comes from the Netherlands, but he's working at the moment in Singapore, and I know he has an excellent collaboration there. And he will share with us on post-discharge prognosis of patients admitted to the hospital for heart failure by world region and national level of income and income disparity. It's a cohort study. I think it's a really interesting topic. And welcome, Dr. Tromp. Looking forward to your presentation.
Well, thank you, Dr. Bax. I'd like to thank you for the kind introduction. Also like to thank the organizers for the invite, for allowing me to speak to you here today. I'm very excited to share with you the 1-year post-discharge outcomes from the REPORT-HF registry. These are my conflicts of interest. So the REPORT-HF registry is the largest global acute heart failure registry to date, where using a single protocol, we included more than 18,000 patients hospitalized for acute heart failure in 44 countries across 358 sites. So the primary aim of the REPORT-HF registry was to compare clinical outcomes as well as quality of care between world regions. So the aim of the present study that I'm going to talk about today was to investigate the 1-year post-discharge mortality differences between world regions classified according to geography, income class, as well as income disparity. So all patients in the REPORT-HF registry were admitted with a primary diagnosis of acute heart failure as determined by the local investigator, and patients were excluded if they had any concomitant participation in a clinical trial. So briefly, when we look at the mean age of patients admitted to hospital across world regions, we see quite some stark differences. So all the way on the left, you see that patients from Southeast Asia had the youngest median age. So in this case, these patients had a median age of 61 years. There was quite some variation, and this went up until 75 years here on the right for patients from Western Europe. So between the oldest and the youngest region, there was almost a 15-year age gap. When we then look at differences in risk factors, we see that patients from Southeast Asia, but also from the Western Pacific, where in this case patients from China and Japan belong to, still had a relatively high burden of risk factors. So 47% of patients from Southeast Asia had a history of hypertension, 42% had a history of diabetes, and up to 51% of patients from Southeast Asia had a previous history of ischemic heart disease. Of course, this is lower compared to some of the risk factors we see in other regions like Eastern Europe, where more than 80% of patients had a previous history of hypertension and more than 60% had a history of ischemic heart disease, or, for example, North America, where we saw that 77% of patients had a previous history of hypertension. So how does this translate to outcome? So the map that you see here is the 1-year adjusted mortality rates adjusted for age and disease severity. And you can see in the dark red, those are countries with the worst 1-year mortality rates. So here, Southeast Asia especially had some of the highest mortality rate, which went up to 46% in Indonesia. We then also classified countries according to country income level, and we saw that compared to lower income countries, the mortality rate was almost 10% higher between lower middle income countries and high income countries when adjusted for confounders. Similarly, we see quite a stark difference in 1-year mortality rate between countries with high versus low income disparity. And in this case, that was up to 4% in univariate analysis. Finally, we saw an interaction between heart failure subtype and country income level, where especially patients with heart failure with a reduced ejection fraction had worse outcomes in lower income countries compared to higher income countries. And that's what you see here. While the difference in 1-year outcomes between patients with preserved ejection fraction was a lot less severe. So this, of course, could suggest that there might be differences in quality or access to care, which particularly would affect patients with heart failure with a reduced ejection fraction. So in summary, we see that patients from lower income countries in Asia are a lot younger. They have a lower risk factor burden, but the post-discharge mortality is still very high in this region, actually among the highest in the world. Patients from lower middle income countries and countries with high income disparity do a lot worse, and especially patients with heart failure with a reduced ejection fraction, which suggests that there might be potential targets for improvement, especially in the quality and access to care. And with that, I'd like to thank you for your attention.
Thank you, Dr. Tromp, for this very interesting talk on an international registry, which is not so frequent. And congratulations for the publication of these findings this year in the Lancet Global Health. It clearly highlights the considerable interest of your findings. I was really surprised by some features. First, it clearly shows, despite some differences between high and low income countries, it shows a constant poor prognosis of heart failure, even if there are differences according to countries. There is a uniform poor prognosis of those patients. And you clearly showed that although in certain regions, patients are much younger than in Western countries or in the United States, finally their prognosis is even worse. Can you elaborate a little bit on that? Is it due to healthcare system, to the profile of heart disease?
Well, thank you, Dr. Iung. I think that's an excellent point. So one of the things that we've noticed is that this poor prognosis especially affects patients with heart failure with a reduced ejection fraction. Well, of course, for these patients, we do have treatment options available, and we see that for patients with HFpEF, so for those patients where we currently have very limited treatment options, there's a lot less difference in 1-year post-discharge outcomes. So this, of course, could be to essentially two reasons. One would be the quality of the healthcare system, where actually patients do not have access to the treatment that they should be getting. And the other one could, of course, also be financial, economic. And I think that's sort of what we're hoping to find out next, where perhaps patients, due to economic reasons, might not be able to afford the treatment that they should get.
Thank you. And I fully agree that one of the interesting findings is the sharp contrast for heart failure due to reduced ejection fraction, while there are not so many differences in preserved ejection fraction, which confirms the frustrating approach we have in heart failure due to preserved ejection fraction. That is that whatever the management, the prognosis remains poor. How could you put these results in perspective with possible actions to improve the patient prognosis in low-income countries? Because those medications for heart failure with reduced ejection fraction are cheap. So how do you think it could be organized with less expense to improve patient prognosis?
Yeah, I think this is an excellent point. So I think, first of all, and this is ongoing results which have not been published, we do see that when we look at, for example, patient insurance status, there seem to be quite some differences in patients with HFrEF in terms of the medications that they're on. So part of the reason why they're not being treated as well as they should, especially in lower income countries, seem to be economic, for example, because they're uninsured. The other part, of course, is the quality of the healthcare system. I think here there's a really big role for professional organizations like the ESC or the AHA in terms of physician education, but also perhaps providing decision support tools that local clinicians can use to actually give the treatment to patients that they need.
Okay, well, thank you very much for for communicating this registry. I think it clearly highlights the importance of setting international registries. That's one of the tasks of the ESC, and we should continue to work with our colleagues worldwide to highlight the interest of such findings. Thank you again.
Thank you very much.
Okay, I'm ready to go.
Okay, then we'll start in 5, 4, 3, 2, 1.
Enjoyable, excellent presentation, the previous one, giving us a really good view on what's going on at a global level in heart failure. Very interesting findings, and congratulations in your Lancet Global Health. Well, with that, we go to the third and last presentation, and this will be given by Dr. Yasuda from Japan, Sendai. Looking forward to his presentation, and he's going to talk about the AFIRE study, atrial fibrillation and ischemic events with rivaroxaban in patients with stable coronary artery disease. Also very hot topic, lots of interest at the moment in atrial fibrillation and coronary disease. Looking forward to your presentation, Dr. Yasuda, please.
Yes, thank you, Professor Box, Professor Young, ladies and gentlemen. I would like to present important evidence from a FIRE trial and introduce the new ESC 2020 guidelines. So this slide discloses the conflict of interest. After 12 months of combination therapy in patients with atrial fibrillation and stable coronary artery disease and not requiring intervention, guidelines recommend monotherapy with oral anticoagulant. However, this approach has yet to be fully supported by evidence from randomized controlled trials. Furthermore, substantial number of patients in this situation continue to be treated with the combination therapy, which indicate a gap between guidelines and clinical practice. FIRE was a multi-center prospective randomized open-label parallel group trial. We randomly assigned a patient with AF who had undergone percutaneous coronary intervention or coronary artery bypass grafting more than 1 year earlier, or who had angiographically confirmed CAD with stenosis of 50% or more, not requiring revascularization, to receive monotherapy with rivaroxaban or combination therapy with rivaroxaban plus a single antiplatelet agent. The trial population received the rivaroxaban dose approved in Japan, 10 mg or 15 mg once daily according to the patient's creatinine clearance. Patients, the primary efficacy endpoint was the composite of stroke, systolic embolism, myocardial infarction, unstable angina requiring revascularization, or death from any cause. Primary safety endpoint was major bleeding, as defined according to the criteria of the ISTH. At the baseline, the characteristics of the patients were similar in the two treatment groups. The mean age was 74 and 79% of patients were a men. 70.6% had undergone previous PCI, and 11.4% had undergone previous coronary bypass. A total of 1,444 patients had undergone coronary stenting with death. The median CHAS score was 2. Median CHAS-DISPAS score was 4, and the median Hasbred score was 2. Among patients in the combination therapy, 70.2% received the aspirin, and 26.8% received the P2Y12 inhibitors. As shown in the left panel, rivaroxaban monotherapy was non-inferior to the combination therapy for the primary efficacy endpoint, with event rate of 1.14% for the monotherapy and 5.75% for the combination therapy. The hazard ratio was 0.72 with p-value below 0.001 for the non-inferiority. In the assessment for the superiority for the primary efficacy endpoint that was not pre-specified, the p-value was 0.02. As shown in the right panel, rivaroxaban monotherapy was superior to the combination therapy for the primary safety endpoint, with event rate of 1.60% for the monotherapy and 2.76% for the combination therapy. Hazard ratio was 0.59 with p-value of 0.01 for the superiority. Our results support the general concept that the rivaroxaban monotherapy without the antiplatelet therapy is a better approach for the patient with AF and stable CAD. Based on the available evidence of higher discontinuation of antiplatelet treatment in patients treated with ORC is recommended after 12 months with class 1 evidence level B in the new 2020 ESC guidelines. So guidelines now recommend that most patients with AF and stable CAD should be on ORC monotherapy. So thank you for your kind attention.
Thank you, Dr. Yasuda. Congratulations for leading this trial, which was published in the New England Journal of Medicine recently. So we really have all trials and registries in this session, which have been published in leading journals. I think this is of utmost interest. And once again, this is important for clinical practice, and it matches the first talk of Dr. Park, because it consistently shows support reducing combined antithrombotic therapy here in a different setting, but it clearly supports monotherapy after coronary revascularization. As in the talk of Professor Park, I was struck by the fact that there was, not surprisingly, a superiority in the primary safety endpoint, that is bleeding, but also in the primary efficacy endpoint. You met the non-inferiority, but also, which was not pre-specified, a superiority, which may be a little bit surprising, because with less antithrombotic therapy, you still have less ischemic event. Can you elaborate on this?
Yeah, thank you very much for this important question. Yeah, I think that inhibition of the major bleeding is very important in the clinical practice, and which may contribute to reduce the ischemic event. So bleeding event is a bad thing, and sometimes we discontinue the medication or reduce the medication, which may introduce the development of ischemic events. So reducing the bleeding event is most important in the monotherapy.
That's really a very relevant findings. As in the talk of Professor Park, you mentioned that you used different doses than in Western countries, which are doses of rivaroxaban which are approved in Japan and which are somewhat lower than in Western countries and in the United States. So once again, it shows the importance of tailored regimen according to the population. Do you think this may limit the extrapolation of your results and the generalizability of your results, or not?
Thank you very much. It's also a very important question, and at the blood level in rivaroxaban of the rivaroxaban was comparable between the patients who received 50% in the Japanese patients and blood level of 20 milligram for the Western population. So from these results, I think that our result applicable and has a generality applicable for the Western population.
Okay, I think it's important to recall that this applies to patients who had coronary vascularization more than 1 year ago before inclusion. So it should not be extrapolated to patients who had very recent coronary stenting, for example.
Our result performed for the patient with stable coronary artery disease. So in the acute phase, of course, the thrombotic risk is high. So I think that there is a merit to for the patient who received antiplatelet therapy.
Okay, thanks again, Dr. Yasuda, and congratulations for this nice trial.
Yeah, thank you very much.
Dear Dr. Park, dear Dr. Tromp, and dear Dr. Yasuda, 3 wonderful, wonderful presentations. Congratulations with your publications as well. Focus on intervention, anticoagulation, focus on heart failure, global health, focus on atrial fibrillation and anticoagulation. 3 very, very timely topics, and so nicely and well done. We enjoyed it all very, very much, and we want to thank you for sharing this with us. I also want to thank Dr. Bernard Iung for having a wonderful discussion with the speakers and highlighting the bits and pieces of these different presentations. I thoroughly enjoyed. I hope you enjoyed. It shows us how the world can come together in Asia and work with the science in Asia and work with the colleagues in Asia. For now, everybody, please stay healthy and hope to see each other in person next year. Have a great meeting.